Now that we've spoken about drug and alcohol related disorders and concurrent disorders, let's go back and touch quickly on 4 disorders that were very briefly introduced in our earlier slides: acquired brain injury, fetal alcohol syndrome, autistic spectrum disorder, and dementia. Why would we look at these disorders? Well, most first responders automatically assume that the disorders that are most important and most prevalent are mood disorders, psychosis and schizophrenia, and drug and alcohol related disorders. And they may be right. Those are certainly going to be important for them to understand and for them to have a toolkit to respond. However, there are a number of other disorders that are quite prevalent as well, and they may not be as obvious in their presentation. So we want you to be able to recognize these and have a skill set for being able to respond as well. The first of these is acquired brain injury, and as we spoke of earlier, acquired brain injuries are caused by an injury after birth. Typically, we think of an ABI as occurring in a late adolescence or later in a person's life from that point. If it happens earlier, we would traditionally start to think of it as more along the lines of an intellectual or developmental disability. And that injury, as we said, could be caused by physical trauma such as an accident or by something like a disease or an oxygen deprivation or sustained drug use. Because the causes of brain injuries are very wide, and so is the type of injury, so is the range of possible effects. If a person has an injury younger in their life versus older in their life, the impact will be different. And if an injury occurs only in an isolated part of the brain, it will be different than if a profound injury affects a larger portion of a person's brain. However, it's safe to say that ABI can affect emotions, behavior, communication, memory, both long and short term, and cognition or thinking. It can affect any of these individually or in any combination. One of the common but not universal impacts of ABI are that the person may experience signs of depression, impulsivity, and anger control issues. And as first responders, these may be reasons why a person with an ABI comes into your facility or somebody you have to encounter. You may also notice that people with ABI commonly, but not always, have difficulties in problem solving, and that may be because their thoughts don't process the same way as they once did, or the synthesis between their memory and their thinking isn't as good as it once might have been. So these problems may be social or logical or both. You have to remember as well that people with ABI are often experiencing a form of loss, a loss of independence, a change in their personality, a change in their self-assessment and value. And this can lead to some emotional adjustments that can be very stressful and may appear as depression or anger issues as well. And these also can have an impact on the relationships people have. For example, we hear from couples who were happily married, and then one person in the couple had a head injury, and afterwards their personality changed, which then caused trauma and difficulties within the relationships themselves. And that's again a reason why first responders may be involved. Fetal alcohol syndrome is our second one we want to look at. As you probably know, it's caused by the consumption of alcohol during pregnancy. And we don't know exactly how much alcohol or what the critical period is, but we do believe that the more alcohol that's consumed, more likely the broader and more profound the effects. But like ABI, the actual range of effects is very, very broad. And sometimes when we hear that a person has FAS, all it's really telling us is that we need to do further investigation because those effects could be mild or profound. One common issue, again similar to ABI, is that the person may have difficulty regulating their emotions, or emotional dysregulation to use the technical term. So again, they may have anger management issues, but it might also be manifested with other emotions, such as, for example, outbursts of happiness where the person is not being particularly socially appropriate. The individual may have difficulty with socialization, reading what's going on and understanding how to apply social rules. One of the common things that we know about people with FAS is that they often have difficulty with what we call generalization, understanding that something they were taught yesterday or a week ago applies to a situation today. And often we find that when we talk with that individual, they genuinely don't seem to understand that the rule they were taught previously can be applied to a slightly different but similar situation. And the caregiver often is frustrated by this because they think, I've covered this ground and I've been clear. The individual may also have difficulty with coping. Again, similar to ABI, they may have difficulty with problem solving or with memory or applying learned lessons to new situations. One thing we might experience as well is alcoholism by the person with FAS. And as a generality, if alcoholism is a bigger issue in the community where you're working, then fetal alcohol syndrome will normally have a higher incidence as well. It stands to reason. But there can be a generational effect of fetal alcohol syndrome. And we're not sure if it's because the genetics have been passed down or whether the kids with FAS are being raised in homes where alcoholism is being socialized. It's probably a bit of both. But it certainly is a relatively common thing to see people who have fetal alcohol syndrome also have alcohol problems. Autistic spectrum disorders deserve particular attention in my view. They're becoming much better known now, and their incidence is estimated at anywhere between 1 in 85 people and 1 in 100 people. So you can imagine as first responders in any one of the systems from which you might be representing, you're going to encounter people who have a disorder that places them on this spectrum. Many people with autism actually have typical or above average IQs. It's a misconception that autism automatically means a person has a developmental or cognitive deficit. And this is particularly true of people who have a disorder called Asperger's disorder. Many people with Asperger's are functioning quite well in society and don't appear to have any type of autism at all until we look at some of the criteria. And there are three main criteria we look at when we consider autism. The first is communication, and people with autism often have delayed development of speech or communication, or they may ultimately only have limited communication. For example, it's quite common for people with autism only to speak in concrete terms or to have a small vocabulary. Their behavior and their communication may be unusual or aberrant. For example, they may repeat what other people say, and this is called echolalia. And echolalia is not written here, but if you're keeping notes, I'll spell it for you. It's ECHOLALIA. And as the name suggests, the person is echoing back what others have said. They're not being defiant when they do this. This is just the way a person with autism may communicate. Similarly, the person may have expressions or ways of communicating that mean something unique to them, and only those who know them closely would understand that. So, for example, I worked with a gentleman who would use the word door to mean he was getting really agitated, and the word jowdy to mean he was being very happy. And jowdy is a completely invented word, but everybody who knew him understood that when he said that, he was very happy. And some people with autism never develop speech at all, but may be able to communicate by using gestures or sounds or by using technology. The second criteria is that the person with autism may have ritualized or repetitive speech. Ritualized means that the person may be very adherent to strict routines. It could be the way that their home is set up, or their time schedule, or the schedule of the way that they see people. Or they might engage in repetitive behaviors such as hand flapping, or rocking, or looking into bright lights, or repeating the same sounds over and over again. And these are referred to as stereotypic behaviors. STEREOTYP. Not stereotypical, stereotypic. And what they are is behaviors that the person uses with a high degree of repetition. The theory being that they use it as a way of blocking out extraneous stimuli. And what we believe about people with autism is that they have a difficult time filtering out things like background noise, buzzing lights, whirring fridges, and so forth. They have a difficulty being able to tell what's the main stimulus and what's the stuff that they're supposed to not be focused on. These behaviors seem to be connected to coping, as I said, and they often come out and look to other people like tics or obsessive compulsive disorder. And so tics are associated often with Tourette disorder. People with autism may have behaviors that resemble Tourette or tendencies that look like an obsession with routine, and so they may be diagnosed with OCD. The final area that qualifies when we're talking about autism are socialization problems. We spoke about part of this a little bit earlier, the difficulty that the individual may have, in communicating abstract concepts or understanding abstract concepts. When we speak to a person with autism, they're often going to be better at understanding when we talk about things that people do and see and feel, as opposed to our emotions or values. For example, saying to somebody with autism, you should do the right thing or you should behave appropriately or fair isn't meaningful, but telling a person to put their hand up before they speak or to stay in their chair is a far more likely concrete thing they'll understand. And people with autism often have difficulty reading the social fabric, and they have this in common with the people we talked about a moment ago who have FAS, although it's more apparent, I would say, in people with autism. What do we mean by reading the social fabric? Imagine that you just come into a classroom and you're talking with somebody as you walk in the hallway, but when you walk in the front of this classroom, you notice that there's a teacher talking at the front and everybody is quiet. You would probably read that as, I need to be quiet, I need to have a seat, I've probably come late. But the person with autism may not pick up on those subtle cues and change their behavior. I like to quote a study that was quoted by Dr. Richard Lavoie in his book, It's So Much Work to Be Your Friend. He talks about a study where two groups of people, some that were diagnosed with autism and some that weren't, were asked to watch a 10-minute clip of a movie. And while they watched the movie, they had their eyes tracked by a device. The people that were not autistic were asked afterwards what had happened in the movie, and they were all able to identify that a couple in the movie had had an argument. And when they looked at where their eyes had tracked, they found that they had been watching the hands and mouths most of the time that they'd been watching of the actors. When they asked the people who had a diagnosis of autism, they got a very wide variety of answers in terms of what was going on in the movie, nothing consistent. And when they looked at where their eyes had gone, they found that the people had been looking at just about everything equally. They looked at the light switches and chairs just as much as the people. And this helps us to get a sense of understanding why it is that an autistic person may not be able to discriminate between what's socially or physically important in an environment and be able to pick up on those cues. And this last portion is one of the main reasons why you might, as a first responder, have interactions with autistic people and sometimes find them frustrating. Especially people who have Asperger's disorder, who might present in every other way as being quite typical. They won't have the communication deficit we spoke of earlier, but they will likely have the socialization deficit. Last one of our disorders we want to speak about very quickly is dementia. Dementia is generally considered the loss of mental and executive functions, meaning our way our mind works and the way we are able to function day to day. Normally, the very first symptom that we notice is the person's loss of memory. It's normally associated with, but not entirely limited to, people who are older than 65. For example, early onset Alzheimer's form dementia can be fairly common in people with Down syndrome, who may experience it anywhere from the age of 40 on. Alzheimer's is just one form of dementia, and it's caused by a buildup of plaques inside of the brain, and it's always terminal. The medications that we give to people with Alzheimer's disease slow down the progression of the disease and help them to be stable as long as possible, but they can't reverse it. Dementia, however, can be caused by many other diseases, including HIV or Huntington's, or by strokes. We have to remember that dementia patients are in decline, and so their behavior yesterday isn't necessarily an indicator of how stable they'll be today. As their symptoms worsen, the person can become disoriented and confused, they may be self-injurious or violent. And so we need to always approach the person with dignity and warmth and be accessible, but we have to always maintain a certain amount of caution. What I've observed is that the average staff person who's getting injured is assuming that this frail older person is not a threat, and that's when they become a threat. Something as simple as tossing a bowl of scalding soup can cause great harm. Many people with dementia are in the care of their families, and so as a result, there can be some challenges as the person's condition progresses. The individual may become violent or angry toward their caregiver, or frustration may ensue the other way, and sometimes we see cases where trauma is occurring in both or either directions between the caregiver and the patient, and in some cases elder abuse or emotional trauma. And again, this is a reason why you as a first responder might be asked to get involved. Now that you've taken a moment to listen to those 4 diagnoses, let's go back to our journal. In your opinion, who's most likely to get a mental illness? Is it predicated on age? Are people who are poor or rich more likely to have a mental illness? Is there a particular ethnic group? What disorders are most prevalent based on your observation and knowledge? Take 5 minutes to write these, and then check the journal and see what others have written.